Introduce the last speaker, Dr. AKPEK. He is head of bone marrow transplantation in Russian University. He's going to talk about novel approaches in GVHD.
Thank you, Dr. Gürman, and thank you, Dr. Beksaç, for your kind invitation. And I'm happy to be here, back to Turkey. Because of the time reason, I'm just going to focus on the treatment of graft versus host disease, acute graft versus host disease. But I'll be available after the session if you have anything specific about chronic graft versus host disease or any other prevention. So the disclosure that I'm going to have to make is this: the slides that I put together is really from the ASBMT. So I have some input from my own, but those are some of the good talks that I just kind of felt like that would be useful to share with you. So in terms of the graft versus host disease prophylaxis, as you can imagine, that there are two ways of doing it. One, you can use T-cell depletion. Those are the sort of agents that you can see, the cyclophosphamide, the post-transplant cyclophosphamide. You can ablate the alloimmunity, and you get very little graft versus host disease. And the ATG and methotrexate and the MMF, those are all T-cell depleting agents to control or prevent graft versus host disease. But if you use sirolimus and tacrolimus and cyclosporin, those are really don't get rid of the T-cells, and you get more graft versus host disease with them. So we tend to really combine with the non-depleting and T-cell depleting agents in clinical practice to be able to minimize or prevent graft versus host disease. So treatment of graft versus host disease, actually, as you know, that the standard of care is methylprednisolone. Is still the case. Methylprednisolone is given 2 mg per kg in 2 to 4 different divided doses, and you get a response rate is about 60% on day 28. And if you get a really high, lower response rate in patients with severe lower GI graft versus host disease. And then there's the steroid refractory acute graft versus host disease. There's not much progress made in that area because there are all these studies that I'm going to really touch base that show variable results that they haven't been confirmed in the other trials, and many drugs have been tried. There are some anecdotal good outcome, but there's no really good standard of care in the secondary. And you cannot see it, but it's a very high non-relapse mortality associated with treating steroid refractory acute graft versus host disease. And how we define a steroid refractory acute graft versus host disease, there are 3 components that you have to really think about it. One of them is actually the progression in at least one organ after a minimum of 3 days of standard to high-dose steroids, or if you don't have any response by day 7, if you have a patient with grade 3-4 graft versus host disease and no response by day 7, is really futile to really insist on a steroid therapy. If you have a patient with a grade 2, you can wait 2 weeks to be able to call it as a steroid refractory acute graft versus host disease. And sometimes we have a patient with some initial response, but those patients are all still on a high doses of steroid, which is more than 0.5 mg per kg, but they actually have their graft versus host disease might flare, and those are the patients that also called steroid refractory graft versus host disease. And this is a very difficult group of patients to study. Even you get some response with some second-line agents. Because of the very depressed immune system, the non-relapse mortality remains high due to infections and organ toxicities. And this is a really good paper published by Paul Martin in BBMT as part of the ASBMT recommendations for the treatment of second-line treatment or upfront treatment of acute graft versus host disease. As you can see, these are the studies. Actually, is in the steroid refractory or second-line therapy. The first graph is showing you the response rate. The complete response rate is about 30%. But if you can see, all these different studies has been sort of depicted here. Some of the responses are really in the sort of 40 to 50%, depends on the number of patients enrolled in that particular study. And there are some like anecdotal case report and case series retrospective studies, which is defined by these diamonds. and you can see like almost 100% response rate in some patients. So these are really sort of curves are showing you the confidence intervals, 95%. The overall sort of complete remission rate is about 35%. This is a survival, a non-relapse at 6 months. Survival is about 45 to 50%. And again, the different studies are showing different results. So there's no really very homogeneity that you can see all these trials reported here. The upfront trial in acute graft versus host disease is one of them, was again performed in BMT-CTN, led by Dr. Lucy from MD Anderson. In this particular study, the patients with newly diagnosed acute graft versus host disease were treated with standard methylprednisolone or steroids 2 mg per kg, and plus there were 4 different agents actually sort of compared, including pentostatin, MMF, deniliquin, ONTAC, and the etanercept, to be able to really find out which of the 4 actually is a better drug in terms of achieving complete remission. And in that particular study, that MMF was found to be the most promising of the 4 agents, with the 60% complete response rate in day 28 and the 64% overall survival at 9 months, and GVHD-free survival was 71% by the day. So this was really sort of very interesting data that I kind of like felt a little bit of surprising, because I don't have a really good confidence in the MMF in treating acute graft versus host disease. But and then this same question apparently was asked by the subsequent BMT-CTN, which actually compared MMF and steroid with placebo, the corticosteroid placebo, comparing with MMF steroid in newly diagnosed acute graft versus host disease. In that particular study, MMF actually failed to improve the GVHD outcomes. Interestingly, this part of this study was sort of like, by some reason, most of the patients actually had an early grade 1 and grade 2 acute graft versus host disease. There were not many grade 3 or grade 4 acute graft versus host disease. And because of the futility rule applied, and the study was closed early, and since they did not see any significant improvement in the day 28 CR rate, 47% with MMF, 45% with placebo, and then the overall survival, early overall survival at day 56 was also 60% versus 50%. And interestingly, when you look at the overall survival at 1 year, placebo group actually did better than the MMF group. So this was a sort of like a death sentence for MMF in combination with the steroid in acute graft versus host disease in the upfront setting. So that there are some efforts in really sort of finding out how we treat the acute graft versus host disease in a better way. So I think there are people, and I believe that the risk adaptive therapy should be developed. And I think this was one of the first initiatives that the patients actually were stratified in low risk or standard risk group, patients who do well with the standard treatment, and then high risk, the patients who do not do well with the standard treatment. So low risk and standard risk. And then the endpoints actually in this new treatment paradigm is, if you can identify those low risk and standard risk, you might want to really sort of find a way to really avoid the toxicity of a steroid and able to taper off the steroid a little bit early, so that you don't really get too much of toxicity up front. And in the high-risk group, the goal is different. The high-risk group, because of the response rate and the outcome is so poor, so that the goal is different, and we would like to be able to really improve the day 28% response rate, which is correlated with the outcome. And then sort of like while doing this, actually improving the non-relapse mortality at the same time. So these are sort of like the current sort of trend in how we really sort of manage patients with acute graft versus host disease. And this was the Minnesota grading actually came out. As we know, that Glucksberg grading system, staging system is still used widely, but this is a sort of new version of grading, and in this particular grading system, the high-risk patients actually were found to be about 15% of the cases, and then there were 3 high-risk definitions based on this grading, based on the number of organs involved, like the one organ. If you have a patient with the stage 4 skin disease, that's a high risk automatically. So even that they don't have any other, manifestation of graft versus host disease, stage 4 skin, or stage 3 and 4 GI, or bilirubin greater than 2 by itself makes the patient as a high-risk category. And then if you have a 2 organ, like any skin GVHD grade 1, plus the grade 2, stage 2 GI, more than a liter of diarrhea, they put the patient into 2 organs, and then it's a high risk as well. Any GI or any liver GVHD makes the patient as a high risk group. If you have 3 of the organs are all involved, they're always high risk. So if you look at the data actually in those different high risk group, response rate is really different. In the high-risk group is about 43% versus 69% in the standard risk, and the 6 months non-relapse mortality is 44% and 22%. So the response and the 6 months non-relapse mortality are the 2 endpoints really we look at GVHD trials. And in order to really define the high-risk patients, in the most recent ASBMT meeting, that there was a sort of a very good presentation from Dr. Ferrara, combining 2 protein. It's just like a TNF receptor 1 and the ST2 were found to be the most optimum sort of biomarkers to predict a response in patients who develop graft versus host disease and start on the steroid therapy or standard therapy. In this, that study actually was originated from their original observation, which was published in Lancet of Hematology in 2015, and they kind of screened all those different proteins, and they found the TNF receptor 1, which is amplified in the GI injury, and ST2 serum tumorigenic antigen, and its ligand IL-33, which is actually sort of found to be a layer, regulating the inflammatory bowel disease activity, and the regular Reg3A is also another one biomarker that also protects intestinal epithelial from the damage. Those 3 biomarkers actually were found to be critical in predicting the response in graft versus host disease, and actually that patients with the GI GVHD, they are not responsive to the therapy, that the most of the non-relapse mortality is GVHD related, more than 80%. This was the sort of data from MD Anderson and University of Michigan. So GI GVHD is really the worst type of acute graft versus host disease to treat with, and we should really sort of pay more attention to those patients because of the high non-relapse mortality. And then this was a sort of like an original paper published in New England Journal of Medicine, ST2 as a marker for risk of therapy-resistant graft versus host diseases and death. And in this particular study, if you look at the sort of curves on the right hand column, the patients with the low STT, this is the first graph is actually showing you the mortality without the relapse, and these are the sort of years. And this is really the highest mortality, the red curve, which actually sort of tells you the high ST2 with the grade 3-4 graft versus host disease. And this is a high ST2, but the grade 1 and 2 graft versus host disease is this orange curve. And if you have a low ST2, even if you have a grade 3-4 GVHD with the low ST2, you can actually have a not a very high mortality rate. So that's really sort of telling you that this biomarker is really very, it could be an important factor that we might be able to use it in the near future. And this is sort of like a mortality with relapse. And so the graft versus host disease did not really have too much of an effect. If the patient relapsing disease, the relapse is the most critical one. And if you have no GVHD, I mean very minimal GVHD is the blue curve and the low ST2, they seem to be a little bit better, did better even if they relapse, but they have a higher relapse-related mortality in that group, which suggests that maybe the higher degree of graft versus host disease is somewhat protective in patients maybe that their relapsing disease is progressing less rapidly, I would say. And if you look at the overall survival again, it's very like just the opposite of this curve that you can see, very short survival in patients who have both high ST2 and grade 3/4 GVHD. So I think that this biomarker was found to be sort of like important, and this was the first graph that I showed you on the previous slide. If you look at only the patients with the lower intestinal graft versus host disease, just the subgroup analysis, if you look at, and actually you get the very similar sort of curves in the lower GI. GVHD alone, and if you look at the right side, this is the patients with isolated skin graft versus host disease, and actually you can separate those patients into two groups based on their ST2, high ST2, and if they are in high ST2, they do worse. So, which means that the isolated graft versus host disease in the skin, you can imagine that those patients are going to respond really well, but if you have a high ST2, those patients are still a higher risk of mortality as compared to low ST2. So this just really tells you that the specific groups also matters, but overall this biomarker seems to be very predictive, as well as in the lower GI GVHD and the less of and the isolated skin GVHD. And plasma ST2 level at day 14 post-transplant was also found to be associated with non-relapse mortality. And this is actually sort of like you can see that these biomarker was measured at baseline at day 14 and day 21. And this is myeloablative versus reduced intensity conditioning. And you can see that the patients who had a high ST2 had a higher rate of death on day 14. I think that just tells you that day 14 ST2 level actually is very predictive for mortality in both myeloablative conditioning as well as non-myeloablative conditioning. And based on this data and the acute GVHD biomarker scores were sort of found, as I said, the three biomarkers were measured in 492 patients, University of Michigan and Rex Emburg's patients, and these were really the training group, 328 and 140 validations. And then subsequently, after this validation, 300 additional BMT CTN patients were looked at and as a second validation, as a multi-center. And they looked at, and they actually used as a 6-month non-relapse mortality as an endpoint, because this was a clean endpoint as opposed to response rate. And this statistical model actually sort of provided the non-relapse mortality for each patient separately. So they kind of like came out with the Ann Arbor score 1 with the non-relapse mortality is equal or less than 10%. Cutoff, and Ann Arbor score 2 is between 10% and 40% non-relapse mortality, and Ann Arbor score 3 is more than 40% non-relapse mortality. So these actually scores were correlated with the day 28 treatment response. And again, as I said, 2 independent cohorts were used to validate these results. And this is sort of like for training sets in the 328 patients. You can see the patients who are CR rate. I mean, I would just look at the CR rate. This is CR plus PR, and you can see the difference between the different scores, Ann Arbor 1 and 2 and 3, Ann Arbor 1 and 2 and 3, and you can see the difference. And then this is the test group, which is actually 164 patients. Again, very similar. I think the most striking is just between the Ann Arbor 1 and Ann Arbor 3. And I think you can actually maybe make an argument that Ann Arbor 1 and Ann Arbor 2 is a really very similar outcome, but the 3 Ann Arbor 3 is definitely indicates a very high risk group in terms of CR rate at day 28, as well as the non-relapse mortality. This is a training set, Ann Arbor 3, 2, and 1, and then relapses are not any different, and overall survival is Ann Arbor 1, 2, and 3, and then this is the training sets, again Ann Arbor 1, 2, 3, 2, 1. It just really tells you that this new Ann Arbor scoring based on the 3 biomarkers were able to really differentiate patients based on what the score is, and in terms of response rate as well as the non-relapse mortality. And then they looked at the Glucksberg 1, 2, and 3, 4, which is the standard one, And actually, you can see, this Ann Arbor score is actually sort of correlating with the non-relapse mortality as well. In the Glucksberg 1, and if you look at only 51 patients with Glucksberg 1, the Ann Arbor 3 is right on the top curve, is the green, the red one, and then the second one is the Ann Arbor 2, and then you cannot see because there was nobody in Ann Arbor 1 actually died. If you have Ann Arbor 1 and Glucksberg 1, then your patients actually won't die with the graft versus host disease. And if you look at the 182 patients with Glucksberg 2, you can separate those patients, and 3-4 is separate those patients. So this new Ann Arbor scoring system using those three biomarkers actually were able to really separate those patients in terms of treatment response and non-relapse mortality. And again, as you can see, his Glucksberg 1 and then the 3, those are really the main difference. You can see the difference. And in terms of probability or predictivity, because this is Glucksberg 1 and this is really a sort of Ann Arbor scores. And so this is really definitely suggesting that this 3, I'm sorry about this slide, kind of like mixed up, but if you look at the benchmark day 28 response in low risk versus high risk acute graft versus host disease, this is non-relapse mortality, this is day 28 response rate. Minnesota low standard versus Ann Arbor 1 and 2, you see very similar non-relapse mortality at 6 months, 44% and then more than 40%. And then day 28 response rate is 69% versus 79%. And the other ones are also very similar. So basically, the message of the slide is actually if you have a low standard, is actually very similar to Ann Arbor 1 and 2. You can use either one actually to be able to predict the response rate and the mortality. So the Joe Anton actually 2 years ago, so based on this sort of new developments in acute GVHD. So if you have a patient, you assess those patients at the time of initial diagnosis of acute graft versus host disease, but you also really look at the new Michigan grading as well as the biomarker assessment. And based on that, the new study was sort of like initiated. So those patients with low standard risk, you remember that in the low standard risk, the goal is really reduce the amount of steroid use upfront in those patients. And they actually randomized prednisone alone versus sirolimus as a treatment of acute graft versus host disease as long as they are in this low standard risk group. And then look at the Ann Arbor scoring. If they are, again, in the low risk group, A1 and 2, just proceed to use this agent. Because if they are Ann Arbor 3, then one could argue that those patients are not going to do well. So treating those patients only with sirolimus may not be ethically acceptable. So they kind of like use this group and also really Ann Arbor 1 and 2, and then randomize to see whether if you can actually get the same response rate with sirolimus as opposed to prednisone as an upfront treatment for acute graft versus host disease. If you have a high-risk patients, this study is going to be open in summer of 2017. It's a phase 2, prednisone plus X or Y or Z, like one of these drugs that you can use, pick up. And for example, in BMT-CTN602, JAK2 inhibitor oral once daily or placebo plus prednisone is going to be compared if you have a high-risk patient. So based on this risk category and the biomarkers and the new grading, the sort of is moving towards a little bit of risk-adapted therapy rather than just treat everybody with the same way. So the last part of my talk is going to be, I'm going to be focusing on the steroid refractory acute graft versus host disease. And this is really based on the Paul Martin paper published in BMT in 2012. As you know, if I ask the question to the audience how you treat your steroid refractory acute graft versus host disease, everybody would say something different probably. And then that's why, and this is not just for this audience or for this place, but I think that it's in the world that nobody actually has a consensus and agreement to how to really treat the second steroid refractory acute graft versus host disease, which is really the main problem in our field, unfortunately. And everybody's trying to find, the best way to really sort of manage those graft versus host disease without increasing non-relapse mortality. Again, the best thing would be really in Turkey as well, really sort of to be able to come up with some sort of protocols, either, small pilot studies to see whether you're going to be able to generate any hypothesis, how you treat those patients in a better way in a well-designed clinical trial. If there's no clinical trial available, obviously there are a variety of drugs that are available to use as a second line. And the main thing is the corticosteroids actually should be really tapered as clinical manifestations improve, because sometimes we overtreat our patient with acute graft versus host disease, and patients actually die of infection and all other complications related to treatment rather than the graft versus host disease itself. So I think the earlier tapering should be considered, using the biomarkers, using the grading. I think you should really sort of take into account all these new definitions to be able to really sort of tailor acute graft versus host disease. I think one of the things that I really am struggling with is when you start your patients, and then if they respond to the graft versus host disease with steroid, and everybody does different things in tapering the steroid. Some people does every 4 days by 25%. Some people does a little bit longer, a little bit less. Unfortunately, there's no really good consensus on that, how you taper the steroids in patients responding to the initial therapy. And in the steroid refractory cases is also more difficult, because you just kind of fear that those patients are going to flare if you do something very quickly. I think those are the things that we really don't know the answers to it, but I think if you have a patient responding to the steroid, you need to really sort of start really tapering relatively quickly, and depends on the risk. So when do you start really second line treatment? If you have a patient worsening GVHD or progressive GVHD despite 3 days of standard treatment or unimproving, I actually gave the slide in the previous if the patient is grade 2 or 1 week of therapy or 2 weeks of therapy, and if you cannot tolerate the high doses of steroid, you're going to start the second line treatment. And the choice of second line, what drug actually you're going to use in the acute graft versus host disease, you've got to look at all these factors really to be able to make that decision, because if you're not familiar with a particular agent, you may not be able to use it properly, and then you don't know the side effects. You have to really be familiar with the agent that you're using it. You've got to take into account an expense and convenience, interactions with other agents, and potential toxicity, and whether the patient actually had been exposed to those previous agents previously. Those are important factors to take into account. Again, while you're doing the second line treatment, because of the second line treatment means escalation immune suppression, you have to really sort of optimize the prophylaxis. Like if the patient is on sirolimus or tacrolimus, make sure that those patients stay on the same drug, and make sure that their levels are really in the therapeutic range, because sometimes patients, have this flare of GVHD and not responding to steroid, but there maybe the tacrolimus or sirolimus, whatever they are on, prophylaxis were not the optimal dose. So you got to make sure that you're really sort of keeping those initial prophylactic agents at the therapeutic level. And some people actually try to use higher dose of steroid, more than 2 mg per kg, and I think those patients actually may not benefit from this, because of the data suggesting that higher dose of steroid didn't increase the efficacy, and actually sort of made more sick the patients. And you should be able to consider really sort of topical therapies, and PUVA or ultraviolet B narrow band for isolated skin GVHD. If you're dealing with the skin GVHD, that's something that you need to consider it. If you have an upper GI or lower GI GVHD, you might consider beclomethasone for upper and budesonide for lower GI GVHD to be able to really taper your steroid treatment relatively quickly. Ursodeoxycholic acid for liver graft versus host disease. And the supportive care is really critical, I think, in my mind, that's really the main thing. If you really cannot follow your patient with steroid refractory GVHD, you shouldn't really escalate immunosuppression. And then the mold-active antifungal agents, like voriconazole, posaconazole, whatever is available. If you have a patient with a higher dose of steroid, 0.5 mg per kg, or CD4 count is less than 200, you got to keep those patients on prophylaxis. And again, you got to really follow those patients for opportunistic infections if they're on really very highly immunosuppressive agents like ATG, pentostatin, or Campat. And then you need to really watch their CMV reactivations and low threshold for treatment. EBV, adenovirus, HHV6, you need to watch them as well. and you also really pay attention to the severe graft versus host disease more than the malignancy, because sometimes, we might really not really hit the GVHD hard enough with the fear of the relapsing disease might be coming back. I think you should really focus on the graft versus host disease management more than the underlying malignancy. So these are the second line treatment options that's been sort of published in the literature. You can see the number of publications on the right column, and these are the sort of agents that are being sort of tested in multiple settings. As you can see, this is anti-CD25, which is an IL-2 receptor antibody, which has been used a lot but didn't turn out to be something beneficial. And ASBMT actually doesn't recommend anti-CD25, doesn't recommend anti-CD3, doesn't recommend mesenchymal stem cells, no recommendation for cyclophosphamide. And then the rest of them are ATG, photopheresis, MMF, anti-TNF, sirolimus, Campat, ONTAC. Those are sort of, yes, you can use it. It doesn't recommendation, but you can use it. There are two new agents that I'm just going to really talk at the later, tocilizumab and the ruxolitinib towards the end of my talk. But this is sort of like the whole recommendation. And I think I'd just like to really touch base with the antigen presentation immunity, how the graft versus host disease occurs. And there has to be some sort of like a little dendritic cell. It was kind of lost by some reason. And the antigen exposure, and this antigen actually presents on the cell surface by the dendritic cell host mostly, and then later on donor. Dendritic cells present these the tissue antigens to the sort of CD4 T cells with the three main signals that you have to really sort of antigen presenting, the T cell receptor, and then the co-stimulation through the CD28 and CD40 ligand. And also the third signal is through the cytokines, IL-6 and IL-23. So after these cross-talks, the T cells actually sort of get proliferated and activated, and then the GVHD starts that way. So if you really want to really induce tolerance without the GVHD, you should be able to really block this co-stimulation in the cytokine and maintain the antigen presenting signal 1. So that's really how you really sort of maintain the tolerance in those patients. And there are like the balance between the pathogenic T cells causing graft versus host disease versus regulatory T cells sort of inducing tolerance, no GVHD. So there has to be a sort of balance between those two. Th17, Th1, and Th2 causes graft versus host disease. And the principle of acute graft versus host treatment actually is sort of controlling this pathogenic T cells while sparing and expanding Tregs so that the tolerance is promoted. So if you look at this second line agents, which one actually does this work? ATG photopheresis, yes, it spares the Tregs. And ATG is something that you use if you have an aggressive graft versus host disease. How I treat steroid refractory, yes. If you have a smoldering graft versus host disease, and then the photopheresis is something that you can consider. It doesn't work in the very aggressive graft versus host, so don't really attempt to use photopheresis in very bad graft versus host disease. But if you have a smoldering, but it's not really getting better, I think the ECP could be a nice second line agent that you can try. And these are the sparing MMF, again, sparing Tregs. And if the patient is on sirolimus as a prophylaxis, then you don't want to use steroid for a long time. I think it's a very good steroid-sparing drug, MMF. And sometimes there's some sort of suggestion that this MMF actually can sort of metabolizes in the liver and actually may help with the liver graft versus host disease better than the other part of the graft versus host disease. But this is a question mark. Anti-TNF, I think there's not much recommendation, but I think there are some studies from Michigan in terms of preventing graft versus host disease. I kind of tend to use anti-TNF if I have a very severe GI GVHD because of the cytokine block. I don't think that you need to use for a long time, but if you want to really control and get the edge of the graft versus host disease, this is something that you might consider it. And sirolimus, again, this is one of the drugs, yes, you need to really sort of monitor the drug level. Sirolimus, make sure it's really 10 or 10 to 15, because if you're using low dose sirolimus, it doesn't really sort of work properly. And they're also sparing Tregs. And the others are really sort of, rarely used, and tocilizumab and ruxolitinib, and looks like likely to use. We need some more data coming out, and so Cyclophosphamide pulse, that I just want to really give you one slide, because cyclophosphamide might be effective in steroid refractory graft versus host disease if the patient has coexistent thrombotic microangiopathy. And this was really the one study that I found in 21 patients with the grade 1 and 3 acute graft versus host disease refractory to steroid, got 1 gram per meter square, 1 to 2 doses, and the CR rate of 52% and 29% PR and 33 months. It's pretty, provocative, but it's just the one particular study that some people might want to consider using it. It wouldn't be wrong. Again, this is the same slide, and I think the purpose of the tocilizumab and ruxolitinib is because this signals, the cytokine part actually can be blocked by tocilizumab, toci, antibody to IL-6 receptor. Ruxolitinib is a JAK1/2 inhibitor or STAT3 inhibitors that actually could be used in acute graft versus host disease treatment. And these are the sort of new potential agents, tocilizumab and ruxolitinib. If you look at the left part, and this is 6 patients were treated, and this was published, and I'm sorry that it doesn't show in the bottom, in 6 patients by Dr. Dubrovsky. And they sort of use 5 infusions average, 48 mg per kg, and then CR rate was 33%, survival was about 50%, but a very short follow-up, an expensive drug. It's, we know that tocilizumab is good for cytokine release syndrome, and looks like sirolimus and tocilizumab combination is underway right now, so we'll hear some more about it. And ruxolitinib is a JAK1/2 inhibitor. It's an oral drug, 5 to 10 mg per PO twice a day, and 6 patients were treated and published in 2014 in Blood. And the grade 2 to 4, 25. I mean, I think, we're kind of like repeating the cycle with the previous drugs that came along. I listed all of them, and we have now new drugs, but I'm not sure whether these drugs are going to really turn out to be really useful. But I think these are really important things, because steroid refractory GVHD is hard to treat. This is something that you might consider treating if you have a patient who didn't respond to anything, and if you can get the drug, and there are some data, it's just kind of emerging. And this was actually the blood paper in the JAK1/2 blockage in graft versus host disease. And it's just really the key points is really reduced. This is a murine study, but also really treated 6 patients in this particular publication. And looks like it helps to control graft versus host disease, as you can see, prior to ruxolitinib. And then it's just like almost very shortly after the ruxolitinib, you can get some response quickly. And you can see all these diarrhea coming down. And these are the patients that are on the corticosteroids and everolimus. And then once you start the ruxolitinib, and then all the diarrhea sort of coming down. And also the sort of, you can see that's the corticosteroid, patient 4, patient 1. And this is the second patient, this is the first patient. You get the diarrhea coming down. You get the bilirubin coming down after ruxolitinib. And also the IL-6 levels are coming down, IL-2 receptors are coming down after the ruxolitinib. So these are really something to really think about it. And this was also a similar study, ruxolitinib in corticosteroid refractory graft versus host disease, sort of helping decreasing the diarrhea and improving liver function tests. These are really the sort of prior to ruxolitinib, after ruxolitinib, and these are the GI manifestations. And then this is really sort of like showing you. But this particular study published in Leukemia, I want to really warn you, because this is something that has not been done as a clinical trial. I think the investigator asked his friends to really tell me about your experience with ruxolitinib, and they got responses as a survey. I'm sure that there are some people did not respond because their results were not good. So don't really get too much excited about it. This is just a survey, multi-center survey. And once you get the response, I think you're very excited. You want to respond to the email that you're getting from your friend. And I think you've got to be really careful interpreting your results. But, there might be some signal in there in terms of ruxolitinib. So that's pretty much it. And this is Chicago, where I live right now. And I'd be happy to answer your question. I'm sorry that maybe I used time a little bit more than I was supposed to, but we started late too, right? Okay. Thank you.
Okay. Thank you for your excellent presentation. Okay, we have some questions.
Yes, please. justified enough yet
to use the biomarkers as the start of of new immunosuppressants before occurrence of the GVHD.
Before occurrence of GVHD, there are some studies actually looking at day 7. I mean, the TNF receptor alpha one actually was the first biomarker sort of published in blood years ago. Actually, if you really check as a baseline and at day 7, and then depends on how many folds of increase between baseline and day 7, you can predict the occurrence of graft versus host disease before it happens. So I think I was sort of waiting to really hear more. I think in this particular, like more recent data, I'm really excited that cautiously, but I'm really happy to be able to really use something in graft versus host disease to be able to tailor my treatment. I think that's the problem, that we don't know how to tailor our treatment in graft versus host disease. That's why we sometimes over-treat our patients or sometimes under-treat our patients. So I think this would be a really good way of really predicting how the patient is going to respond.
The question always comes up, you have somebody who's on steroids, they determine they're steroid refractory, and what do you do with the steroids?